Well, greetings again. This is Dr. Bill Wyatt with the American Orthodontic Society, and I'm going to talk with you today. I've got an interesting case here. It's one of the only one I've did during my whole practice, and that's a tongue reduction case. And I had been to see a French orthodontist or oral surgeon that worked at Baylor for a while, and he did tongue reductions. And he put on a big lecture up in Chicago, and I went to hear that lecture. And he showed a person with the teeth that stuck out like this, and he did nothing but took out a section of the tongue, was way too big, and the person's teeth just kind of closed back in like that. Of course, this is a tongue thrust thing, and I've had several people through the years that really needed that, and I would suggest it, but it's not a practice building thing that you do for somebody. But I did have this one young man, and I'm going to show him, and he also has two badly impacted cuspids, which we'll cover both. So let's get going here, and I'll get started. This he was on a swimming team, and he had a lot of skin problems too. In addition to this, you can see all those little bumps on his head, and now when you close his teeth as far as you can get them together, they wouldn't touch, and the teeth were separated out here, just had spaces between all of these teeth. And he had these two badly impacted cuspids coming in from way up in this area, and their roots were right up behind the roots of the central teeth right here. And all this is just big gaps in here. And I got the impactions out and pulled them in place and got everything, and I closed it up and it opened right back up again. So they agreed to have the tongue reduced. And I finally got an ENT guy that would do this, and he checked on Dr. Andre Petit's record there in Dallas and talked to the oral surgeon that did the tongue reduction, and so he went ahead and did it for me. So I'll show this case to you. Let's get started here, and you see it's open. He only touches back here, and the teeth were coming together. His tongue is just filled in this whole gap right here. And that's on the right side. Let me see, on the left side's virtually the same. He does hit the anterior tooth right here, kind of class 3-like problem. And these are some baby teeth right in here that are still there. And these cuspids are up in this area right in here, behind the centrals. And I sent him to an oral surgeon to uncover these cuspids, and he did it. They really go after it when they uncover them. And one case over here, he went all the way over, and you just don't want to do that. That makes this attachment messes it up, so you leave some space in there. So let's get going. We'll show that in just a minute. Now on the bottom, it's everything. He's just got spaces everywhere in the mouth. And this is it was taken back in 1985, and you can see the lower teeth and upper teeth come together in spaces all between here, and he's got wisdom teeth back in behind those. Now here we go again. This is a little better x-ray. There's one of these wisdom teeth that's missing here, but he has one up above and over here and over here. And I think we ended up, after we closed all this up, we may have taken these back or may have left them and let them fill in some of that space. Now you can see the impacted cuspids right in here. And they're large teeth. And so I'm going to erase that, and you can take a look at it better and see where the roots are. Now when you're doing impactions, you want to get the attachment where you're pulling on as close to the tip of the teeth as you can, and then we'll try to open a gap in here or keep it open and pull that in that direction. And then you try to go there. And the deal we've got worked up for impactions is the best I've ever seen. I'm sorry I came up with it, but I worked for years figuring out how to get it there. And then we're going to close this up. But if you look careful now, you'll see the root of a baby tooth right in here. You see a piece of root over here. Leave those alone. They usually just disappear after a while. Now let's go on and look at the next Panorex X-ray. It's number 2. And so we're going to take out these deciduous cuspid teeth and bring the permanent cuspid down into the place. And you can see this ate the root off of this right here, but it just wasn't having, sometimes your permanent teeth don't eat away the baby tooth as good as they should. The follicle around the cuspids usually eats the deciduous tooth away a good bit of distance between there and where the tooth is going, and the tooth will come on in the mouth good. Now I sent him into an oral surgeon to have him open this up, and I didn't want him to do it that big. I just wanted him to luxate those teeth, but I felt like they were ankylosed, and so I had him luxate them and uncover those teeth, and you can see it a little better there. Now here we went in and we put a bracket on the front of those teeth. I'm sorry there, let me get my eye cleared out here. We put a bracket, and then we would take a piece of 014, 14 thousandths 0.014, and that soft stainless steel wire, you can twist it, and then you come out here and make a hook in it, and you can pull on that with about 5 pounds before you straighten that hook out. And so that's what we normally do, and we make a arch wire going in here, and then we'll make a circle in it like that. Come around over here, and we'll make another circle, and then we will run that floss dental into here and come back to the molar with a spring, and a floss we'll tie onto that. That's kind of the way we brought the teeth in the mouth. So let's get on from there. Here it is now after he got back from the surgeon, and I think they took too much tissue, but you can take tissue out of the palate. It's not as bad. You don't want to take the tissue out of the front part up here. You leave it alone if possible. And I'm sure this was out alone too. We started pulling that together there, closing those teeth. Now here is a mistake, really, in removing the tissue here. You could take that much, it'll still fill in, but stay away from this attachment on the teeth. Don't get up there, but here it did. And so you're going to have a permanent dip in the tissue right here. So if you're doing this yourself, I just like to come in here with a place about like that and take electrosurge and cauterize it, and then make my hook that I'm going to put on the tooth, put it on there, and then twist this wire. I have this wire twisted and ready to come out side so I can hook it. And then you come in here and you make your circle on that spring, on that wire, and you run this dental floss. You just run the spring from the back of this motor all the way up, and you pull it from there up to there, and you got dental floss going in, and hook it in here and come back out, and these two ends you tie together, and that'll pull that tooth right to that spot. Now, let's take a next look at it and watch it later on as we go. I'm going to erase that, and this is opening the gap big enough. We put spring on there, and we spread it out, and we making this gap even bigger than it was. We push these teeth together, and I pull all these down on the bottom and start getting them together. Now the elastic we used, instead of the spring from here up to this hole, we just went straight off of this tooth up to the other tooth to come in. Now this type of pull right here helps you develop a class 2 problem. It actually pulls this teeth forward down here, and as it pulls these down, it pulls the lower teeth forwards. So you can correct class 2 problems sometimes in an impaction by pulling it. That'll pull all these teeth together, close this gap up here as you pull that cuspid down and pull it over to the center of that place there. That's not exactly like our regular impaction mechanics. Now, here we put these brackets on, and normally I make the wire and put it on the bracket before I bond it to the tooth. But this was a little earlier than that, and you got to go in and hook this, and you twist this up and make a crook in it down here. Go around the tooth, come up, make you a hook, and then you got this opening, and you pull it toward that spot right there. But always pull from the tip end and get closer even than I got there. All right, now here we'll go. All right, we're pulling that tooth down in that direction, and we close this space up over here. We close these together, and we are moving this too as we move the cuspids down. Now there are the cuspids. We got down to one spot, and I tied some chain on it here. This was before, really before we worked out our good system of bringing cuspids in. So this was a little bit before that, 1986. So I didn't get that perfected until 88 or something like that. Now they're pulling in with elastics down there, so he had to hook the elastics to it. Now this shows you the tissue grew back in just real good, but right here we had this gap. You see how I did. Now up here he had a space in there, and it ended up real good there. So if you cut into your uncovering impactions, stay away from the tooth where the tissue that joins the tooth. Don't cut in there. Cut back and leave some around it. And then these teeth are moving in that direction. This is not an efficient way to do that. The stuff we had with the spring coming from here and then the dental floss coming here is the best way I've ever seen to do that. You can go back over on our impaction mechanics and you'll have a whole video on that. All right, this is 8 looks like 802 of 86, and we've got the teeth coming in, and we've got the gaps closed up pretty much. And let's go ahead with the next. Looking on the other side, the tooth's coming down over here about the same way, and we've got this space closing up on the bottom, and we continue to close that. And I got it closed up, so we got the cuspids in here, and we've shown you how to put an arch wire in here, and you want to turn that tooth in this direction. So you have to run something around and put some acrylic there and come back to the bracket up here, and it'll turn in that direction. You can pick that out on rotation of teeth. Now here we've got it this far, and this is 1987 and 9 of 87. The bottom's pretty well closed together. We got the cuspids in place now, and we've closed the gap. But the teeth just kept opening up in here. I could not get it closed. And so I talked to the parents about, he has this oversized tongue. The tongue is, it looked like you had to wad it up to get it in the mouth. And so I sent him to Baylor, and they couldn't figure out, back when Dr. Andre Petit was doing that, but I talked to a ENT guy that had done a lot of work for me, and he took part of the portion of this tongue out, right down the middle. He cut a strip that's an inch wide and about 3 inches long down the middle, and tapered it together, pulled the tongue together, and he said when he got it in there, he thought, well, I didn't get enough off of it to start with. So anyway, the tongue was huge, and I guess you just inherited a tongue large like that. I've never had anybody else that would submit to this operation, but we have had 4 or 5 people that really needed it over a period of time. And so we had that taken out, and he went in, and the tongue was just huge and was still trying to separate the teeth. I couldn't get them together, get them to stay. I could pull them, force them in there, but you can't turn them loose and they'd stay. So they agreed to this tongue operation. Now you see this gap right here where the tissue was taken away wrong. However, it's not all that good over here on this side. But these teeth have been pulled from here up to there, and it would pull through that tissue like that. Now, after I got them in there, I couldn't get that space to stay open. And so I talked to the parents about this, and we went over it and sent him to the ENT guy. And this is after the teeth was cut and taken out. And actually the guy said, I took a inch strip of tissue from here all the way up and kind of tapered it in back at the back, sutured it together and everything. And this is after it's sutured together. I'll show that. You can see where it was done. And that doesn't affect the taste buds are over on the sides of the tongue. And it didn't seem to bother it, or he's talking. And now we could pull these teeth together and get them to stay. But I've either lost or didn't get the finishing picture of this case. But that's somebody, and it does look like the tongue's too darn big, and the guy said he cut a whole inch strip out of the center of this tongue to do that. And see where it's been sewed together here. But it's still got a large tongue. But we got enough off of it to where we could pull the teeth together and get them to stay. And that's the way it looks back in 1988, 4 of 88. And I close up with that. I'm sorry I don't have the finishing pictures of his case, but this is the only case I ever did where we did a tongue reduction. And so hope you understand that, but that is something that needs to be done on a few patients, but not a lot of them. And that's the impactions up there. We do that in the better ways. Thank you for watching, and I appreciate your help, and I want you to join our group and subscribe to it, and we appreciate it. And we have these in Facebook now, and also there's one other thing, we're putting the videos in them. But thanks for watching, and if you have any friends who want to know about orthodontics, we appreciate you telling them about it too. Thank you very much, and I'm going to close out